Okay. Um, Hi, everyone. My name is Julia Bova, and I'll be kicking off this morphine milligram equivalent webinar. I'm just going to wait 1 minute since it does seem like we have a lot of people that have already joined and more that are coming in. Um, we have the settings to mute everyone when they come in, but if everyone could also just make sure you're muted as you come in, since we do have about 250 registrants. Okay, well, now it's 12:02, so I'm going to go ahead and get started. Hi, everyone. My name is Julia Bova, and I'm a program analyst at the NIH, and I help oversee the HEAL Initiative Common Data Elements program. I just wanted to thank everyone who's joining this webinar today about a new morphine milligram equivalent, or MME, online calculator that the HEAL Initiative is excited to launch. And we're really excited to have Dr. Meredith Adams from Wake Forest University, as well as Dr. Kathy Sword from the University of Utah, here today on this webinar, who are going to demo this tool for us and answer some questions. You could go to the next slide. So this is our agenda for today. I'm going to briefly explain what the HEAL Common Data Elements program is, and then my colleague, Dr. Shelley Su from the National Institute of Drug Abuse, will discuss the general need for standardizing MME data within HEAL research. And then Dr. Adams and Dr. Sword will demonstrate how researchers can use this tool. And then we're hoping to leave about 15 minutes at the end of the webinar to answer some questions from attendees about how to use the tool. Next slide. So I think many on this call may already be familiar with the HEAL Common Data Elements program, but I do want to provide a bit of background information. So the HEAL CDE program is an initiative that was started in 2020 to standardize data collection among clinical pain studies that are funded by the NIH Helping to End Addiction Long-Term Initiative. So we require all HEAL-funded pain studies that involve human subjects to collect a common set of patient-reported outcome screening tools. As I mentioned, this started in 2020, and the domains or outcomes that are covered by this cover biological, social, and psychological study outcomes. And then there's an associated questionnaire for each outcome that we've identified that's important. And so the idea behind this program was basically to be able to have comparable data sets across different pain conditions, different populations, and different study interventions, with the overall goal to be able to have secondary data analyses and quantify the impacts of interventions over time. So this table here on the slide shows just the requirements for the adult chronic pain group. And so in the first row, you'll see that these were the domains that experts agreed were important for pain studies to measure. And then the row below that shows the associated set of screening tools that HEAL-funded pain studies are required to use to collect the data. And just important to note here that this is just for adult chronic pain. We also have separate requirements for adult acute pain and then pediatric studies. As I mentioned, this is just a brief overview of the program, and I'm happy to answer other questions in the chat. But in efforts to talk more about the calculator and the MME requirements, I'm going to go ahead and hand it over to Dr. Shelley Su, and she's going to go into more details about the morphine milligram equivalents and the HEAL requirements specific for collecting this data.
Thanks, Julia. So there's a very long and rich, long-standing history on the use of MMEs. It was initially created to help clinicians determine opioid doses that were equivalent to morphine. There have been numerous calculators and conversion tables published in the literature and also by public health organizations. And so I wanted to share a little bit of new and updated information that served as the foundation for why we created this tool and why the HEAL CDE program was requiring opioid use data collection. Now, obviously, in the last 15 to 20 years, there's been such a large spike in opioid prescribing that suits different needs for our patient community. And there are 4 different ways that one can actually calculate a daily MME. You see the list of those calculations here. And one thing to note is that the reason why these calculations exist is that they can often serve very different purposes. So for example, maximum daily dose calculations are used to estimate an overdose potential. And this was a function that really emerged during the opioid crisis when we saw such a large and devastating rise in overdose deaths stemming from opioid use and now other substances. The other definitions are used to help address the fluidity in opioid prescribing, whether that's being used for opioids on a daily basis for things like breakthrough pain, or in different opioid regimens throughout the course of treatment for a particular patient. The other thing to note is that the calculation definitions do tend to vary by approach. So if you're collecting data, patient-reported data or data from EHR in a clinical trial, that's going to provide a lot more granularity and context than other approaches, such as those provided in a prescription drug monitoring program or PDMP. And then also things like claims data will allow different types of calculations. Next slide. So the reason why we're here is because these different calculations can produce very wildly different amounts of daily MMEs. And so standardization across those definitions and automated standardization provides an opportunity for us to enable cross-trial comparisons within the HEAL clinical pain research portfolio. And so this opportunity now provides an additional benefit for us to evaluate other opioids that have been excluded from prior MME calculators, as well as explore the utility of underutilized opioids for pain management, things like buprenorphine. I mentioned before that when we standardize and automate these calculations, it allows researchers, public health officials, and NIH program staff to compare health outcomes across the various trials that are funded within the HEAL clinical pain portfolio. And the other additional opportunity is that we are able to adjust various conversion factors based on the growing evidence and data that will come to light over the next few years. Next slide. So here are some of the requirements for MME data collection. Again, this is intended for dispensed, or actually it's really prescribed. It's hard to measure dispense unless you're talking about very unique circumstances, but it's supposed to be for opioids for pain management only. We're going to be reporting these. We're asking that you report these as daily MME, and our tool will help you with calculating those values. I cannot stress this enough. The purpose of this tool is intended to answer research questions. This tool enables meta-analytic opportunities in the future. You should not be using this tool to inform any clinical decision-making, nor should this tool be integrated into any existing health system. And we can go into a little in the Q&A about the justifications for those, but I cannot stress this enough. This tool should be used only for research purposes. It's recommended that you collect these MME data at 2 different time points. One suggested time point is at baseline, and then at another follow-up period that makes sense for your unique trial. And it's also recommended that studies within a particular network or a particular circumstance harmonize on that time point and sampling frame as well. There's going to be 2 ways to collect these data. The first is the REDCap data dictionary that Dr. Adams and Sword developed, and they'll be reporting more on that in just a moment. And then there's also the online MME calculator tool that stems from this case report form. Next slide. So who is required to use this tool? If you are funded under the HEAL Clinical Pain Group, if you're exploring or documenting pain outcomes and related to opioid use, funded by HEAL. You are supposed to be using this tool. I think it's set for programs that were funded in FY23 and later. And again, this tool is intended for research purposes only. Clinical judgment should not be using this tool in a healthcare setting with patients. The other thing that I would like to stress is that you should not be using this tool to evaluate opioid medications for the treatment of opioid use disorder. So this includes analgesics such as methadone and buprenorphine. And I think that concludes my portion of the webinar. Thank you.
Okay. Well, I want to start by thanking the HEAL Initiative, Dr. Sue, Dr. Wandner, and all of our NIH colleagues that supported sort of the development of this, because it was a process, as we're going to walk you through here, to get through. I think it's an amazing thing to be working towards this type of standardization with the work that all of us do. And, really with that, our goal here was to kind of take the mission of figuring out a way to collect this in a standardized fashion and make it as usable for as many investigators as we could. Again, emphasizing that this is not for clinical use. This is for research. In fact, the website is research.mme, and that's on purpose because we want people to realize that these were developed to convert research data around pain prescribing of opioids. The chart here is very hard to read. The whole point of it is just to point out that in the paper that I'm just going to show you a slide of a little bit later, we do have information showing what the 2016 CDC guidelines were, the 2022, and that really the numbers that we used were not that different. One of the big things as we dove into this, going back to the literature from the 1940s even, is that we don't have great primary source data. And that's why we need these, is because we need to develop better data and better research that'll support, the best possible use or sort of management of pain that involves opioids. Next slide, please. Maybe. So this is the paper that I'm referencing. So all of the details in the supplemental files and the main document talk about everything that went in there, what we did for the literature review. What we really wanted to do was make sure that the whole process was transparent so that you understand how we came up with the numbers and how all of this was pulled together with the definitions. So there's a lot of information in both the main document, and then take the time, if you will, to check out those supplemental files so that you can actually see, if you're looking for the why of, how this came together. We got a lot of questions from registrants. Thank you so much for putting those in advance. And some of them I think will be best answered there. We're going to be focusing on the logistics of using the website and the calculators during this webinar, and we're happy to have separate offline conversations, maybe other talks about the actual science behind what we did with the development. Next slide, please. Okay, so I cannot thank the CDE team enough because, as I mentioned, this was a process. Dr. Sword and I have worked together on other CDE projects, and I would say this one was, I don't know how many versions, 20 something going back and forth, something like, maybe that's a conservative estimate. And this is why we built a REDCap version of this for you guys. But if you want to find out the information, you can go to the CDE website, and it has more detailed information about all of the different CDEs, specifically about prescription opioid use. Next slide, please. And then if you need the actual file for this from the REDCap, it's there in the CDE repository with the CRF, or you can reach out to the CDE team and they will always be willing to help you out with that. Something that I really wanted to mention with the REDCap files is that a lot of times when we are fielding these with networks, we get a lot of questions saying my REDCap file is not working, my, this and that. The first stop that I would tell anybody is to reach out to your REDCap administrator at your institution, because sometimes there are permissions or things that are unique to your own environment. We're happy to try and field, and I know the CDE team is also is happy to try and field, but some of it is very institution specific. So the first stop might be to have your internal REDCap team just run a check on it and make sure that there's nothing that's blocking it from their side or causing difficulties. And they can usually diagnose that pretty quickly. Next slide, please. And this is just showing you. There we go. So, yep. Next slide is fine. Okay, so this is what the REDCap survey looks like. There's information that has all of your details that have to do with the different definitions, which again are based on pain and not about opioid use disorder. And it hopefully gives you enough information to really understand why we're doing it, what the different definition means. And, you know, you may come into this with your study design and know that you're going to use one or two of these definitions. You may be using all of the definitions. The way that we structure the data collection should allow for maximum flexibility. The downside of this is that, as we discovered, Dr. Swart and I, it's very complex programming, lots of troubleshooting to get us there. So the thought of having a pre-done version of this for you was that you do not have to reinvent the wheel here, but that also, you know, if we gave everybody just the CRF, we probably would have 50 different versions of how the data actually sort of went through and built. And so this hopefully keeps it consistent and easy for that secondary data analysis and those later data combinations. Dr. Swart, was there anything you wanted to add on the REDCap side of things?
No, I think you've covered it.
Okay, awesome. Next slide, please. And this is just the list there of the different drugs that we've got there. We have long-acting and short-acting versions that are included. And the only, we've got buprenorphine, which is there as something that can be added as an inclusion or excluded from the analysis to give you a different set of numbers for both. Next slide, please. And this just shows you what a REDCap field survey would look like and how it would calculate that. There is some skip logic, so if you're not using something, you shouldn't be seeing screens. And hopefully when you get this installed and work with your local team, this will be very functional for you for your studies. Next slide, please. And again, this is just kind of showing some of the definitions, and this version has excluding buprenorphine, so it's going to have different numbers than ones that would have it with it if you had that as a drug. And that allows you to sort of compare what those numbers look like with and without. Next slide, please. Okay, so recognizing that not every study is going to be using REDCap, we thought that there needed to be potential alternate ways to do this. So you have the CRF. So if there's something where you were fielding with paper, which, you know, that's its own entity, but we wanted to have potentially a website that would make it easier for you to do this in an automated way and have those calculations sort of be consistent across. Let's go to the next slide. Okay, so you'll see a lovely blue little indicator there saying that why we have this here and what it's for, and that this is for research. We're going to reemphasize 895 more times. This is for research, folks. This isn't for prospective clinical use. There, of course, you know, you would be potentially taking data that had been collected for clinical and you could transform it using this, but it is not meant to be making clinical decisions at all. And the other thing that we have here is something that says login with ORCID, and that we'll go to the next slide, please. So an ORCID ID is getting to be a pretty common identifier that people can register for. There's nothing proprietary that you need to be able to do that, but it allows us to have access and password management that it doesn't require a person to sit here and maintain for that. But it's something that a lot of papers, the NIH are requiring it now on your BioSketch. So hopefully if you haven't had that already, this is something that you're able to just sign up for in a couple of minutes and then have that available. This is not limited to certain ORCID IDs. We have instances where things are, but for this one, it's wide open. As long as you have an ORCID ID, you can access it. Next slide. Okay, so I'm going to run through the website functionality overview. This is something where the first time that you go into the website, all of this little tour will be there, but it's really just to show you what's available, what's possible, and how to navigate. Hopefully it's not too complicated, but we just wanted to have explainers on there so that people would be able to do that. So your first step is you're going to be, looking at your drugs and picking what you need. Next slide, please. And then as you click those, they'll show up in that top bar with the drugs that you have. Okay, next slide, please. And then from there, it's going to pop up with different definitions and show you how it lands based on the information that you're putting in there. Next slide. And there are, as we said, sort of different possibilities. Some of the definitions require things like on therapy days and observation windows to do those calculations. If you don't have that information entered, it won't be able to populate those definitions for you. So those are hard stops on that, just to make sure that you have the information that allows the calculation to occur. Next slide, please. And then we're showing here on the left side, those are the total MME without buprenorphine. And on the right side, we have them with buprenorphine so that you can see those numbers separately, depending on what you're doing with your research question. Some areas may or may not be relevant. And when you're combining the data with other studies, there may be benefit to having that included or not included. And we wanted to give you as much flexibility as we could build in on the front end. Next slide, please. So up along the top, and actually we have a new edition that's not there. There is a link to the PDF as well. So if you wanted to reference the papers and you get a little confused, you want to know why they did something or why one number looks a certain way, you can do that. You can also, in the paper, there in one of the supplementary files is a use case of the definitions. So if you're getting started and you just want to play with this and you don't have your own information, if you want to see how it adds up, you can punch in that information and just do your own check of it and see this is how it calculates out and this is what it does. But this has information on the definitions again, and then how you move along through that. Next slide, please. There is something here called API, which is an application programming interface. What that is a connection. So this website that is the calculator can be connected to databases. So if you have an existing database, if you've got information that's already there, say you have a database of research information that you pulled from a registry or a clinical trial, or even EHR data that's already been cleaned, you can then connect this. We did receive a question about, can you work this calculator with things like programming, like R and SAS? And because we have the API, there are packages in those softwares that allow you to do that. So that's beyond the scope of this talk to talk about how you would work that. And quite honestly, you can Google that pretty easily, but your team should be able to manage it if they're working in R or SAS. But having this API capability allows you to actually be able to do that and then have that interface. So, what we're trying to do is make it so that as many people as possible can use this seamlessly for different applications. Next slide, please. And that's that API. Next slide, please. Okay. I'm not sure if I saw it, but one thing that I really wanted to also emphasize here was that we do not store your information. So if you're entering information about the opioids, you're entering your study information, it is not going to be maintained. So make sure you take it with you. There's export at the top. There's an Excel that allows you to just take whatever you've entered and export it as a file. But it will not be maintained. There's not a link to your login that's going to have queries that you've run or anything like that. We are not retaining any opioid-related information. Next slide, please. And again, there's little pop-ups everywhere if you need them, where you can refresh your memory on what the definitions are, how they're calculated, the math that goes into them, and how the magic happens. Next slide, please. All right, so entering, this is just a sample. So you're putting in your dose, you're putting in your number of 24-hour doses, and you're putting in your duration of your days. And you can see across the top that it populates and you get this nice little line that has your information there. Next slide, please. Okay, and then you can add your second one. And in this case, it was a short acting and a long acting oxycodone. I think for this demo, we actually used the information from the paper that had just the samples so that you can see how things calculated out. And you'll notice in this slide that the on therapy days and the observation windows haven't been answered. And so you have a not applicable in definition 2 and 3 because they need that information to be able to calculate it. Next slide, please. And now that that information's in there, you can get those calculations, which is handy. And over on that right side, because they weren't entered in the with buprenorphine, it stays not applicable over there. Okay, next slide. Exporting data, this I'm re-emphasizing one more time. We do not retain any record of the information. Again, for the bazillionth time, please do not use this for clinical care. Thank you. Next slide, please. Okay, and so here we go. Don't see it moving. Okay, well, up on the right, there's a little green. Oh, there we go. Perfect. A little green, and you tap on that, and it says export to Excel. Next slide, please. And that's what it looks like. So it has the same names of the components across the top, and then you can go from there. And so this is how, if you were building your connection with the API, you could take it and it would analyze your information, kind of using those same types of variable names. And what we tried to do was keep the variable names similar to what we had with the REDCap as well, so that would be compatible. Next slide. All right, we have moved on to the question portion of this. Dr. Sword, did you have any other thoughts on all this? Because you were part of a lot of that programming and components as well.
You covered it very well, thanks.
I'm going to have to thank my program manager, Kara McDonald, who did an amazing job of learning how to actually do all those little clips, because my big fear with this type of presentation is we take you to the website and something's not working. And this way, everyone can see sort of the action shots of how it happens. So thank you, team.
Wonderful. Well, thank you, Dr. Adams, for that presentation. We have quite a few questions in the chat, as well as questions from when participants registered. So how does the HEAL initiative address the adjustments in frequency, dosing, and duration in opioid use, such as chronic pain and acute pain of patient use and scripting?
I can take a small portion of that just to say that this was developed for chronic pain and not necessarily acute pain, because there may be some components where you're taking these as outpatient, but there's not IV dosing or some of the dosing built in that has that aspect of acute pain with it.
Great, thank you. And will a future version allow provisional entries for experimental opioids in development? This would be useful reporting in the HEAL Common Data Elements program. I'd like to take that.
Well, so Shelley, I think this is a you and Laura question about.
I was going to say this is an NINDS questions.
Yeah, I think it's something that we will consider for the future. As of now, the calculator is locked, but the way that it was developed was it enables us to add new medications in the future. So we're happy to talk offline if there are some topics that are relevant here.
And I'll just add that as data become, somebody in the chat brought up the issue with buprenorphine, and as more pharmacokinetic data comes out, as we learn more about fentanyl's mechanisms of actions, we can sort of update some of that information, the conversion factor, appropriately.
Great. Now we have another question. What is the difference between this calculator and the one on the website of, let's see, the agency med directors? .wa.gov.
So I believe we looked at this the other day. That website, A, has a smaller list of medications. I don't know what conversion factors it uses. And the other thing I saw on that website is that it only allows you to enter 1 day of medication at a time. So you can't calculate that a person got 10 days of medication on that page. You can only do like, what did they get per day?
Great. Thank you, Dr. Sword. What data was used in order to generate the conversion tables and ratios?
Great question. It is all in the files of the paper, the manuscript that we mentioned. It has all the sort of primary source that we used. It has every single reference. I think some of the critiques of some proprietary calculators and some previous guidelines is that the sort of decision-making of how numbers were used wasn't transparent. And so what we really wanted to do is make sure that every single medication, whatever the level of evidence that we had that was the best, is clear so that you can see what drove the decision-making.
Great. Thank you, Dr. Adams. And Julia, I believe this one is going to be for you. Is it required for all NIH funded grants, even those conducted prior to the calculator's release?
Yeah, this came in through the registration, so we may have answered this already, but I just wanted to reiterate that this is not required for all NIH-funded grants. The MME requirements are for HEAL studies that are clinical pain studies with human subjects. And then to clarify even a little further, the MME is required as of 2023 studies forward, and you are not required to use this online calculator to calculate the MMEs. You are required to report all of the data that goes into the calculator to make the calculations anyway. So that's why we're hosting the webinar and we recommend it. But it is just for HEAL initiative studies that are pain focused, that are clinical studies with human subjects, and the data can be reported with the calculator or without the calculator.
Great. Thank you, Julia. All right.
Can I add one
go
thing,
ahead.
Carolyn?
Yeah.
Just, as an investigator who works with a lot of these studies where they're combining different components, I would say it's not a requirement. And if it's a burden, I can understand why you wouldn't necessarily want to adapt. But the hope is that this is going to be, there's going to be a standard moving forward. So if you can align your work with that standard, it gives your work more power to be able to sort of see what's happening, and it connects you to these other studies in a way that can be very meaningful, hopefully for both your work and then the larger work in the field.
Thank you. All right. Is there any utility for using this for research for patients who do not have a prescription or who are not pain patients?
So
No. Is a simple answer. Please do not use this for any other indication than opioid use for pain management only. Please do not bring this into your healthcare system. Please do not use this tool to help you advise on care for your patients. This is really only for research purposes only, to enable cross-trial outcome comparisons through meta-analysis. This is not at all used for folks who are on opioid use disorder. We've seen some misapplication of prior calculators to individuals with opioid use disorder, and that did not end well. So we're not repeating that cycle. This is only for pain outcomes only.
Thank you, Dr. Sue. And just a reminder, if you have questions, just put them in the chat. I'm reading them strictly from the chat and the questions we received from registration. So the next one we have is all of the online MME conversion tables stress that their calculations are for oral medications only. Does HEALS follow suit?
We do have a couple of transdermal, like a fentanyl patch transdermal, but for the most part, this is oral. I think a lot of times that question is, do you have IV or sort of other, but for the most part, other than like buccal patches and for buprenorphine, I think, and then transdermal fentanyl, this is primarily oral.
Thank you, Dr. Adams. For perioperative pain control, does pre-op opioid use and post-op opioid use within the same day count as 2 time points?
It's more of a study design question, but as an anesthesiologist, I would say yes.
Thank you. Is it possible to get that API call for our users?
Yes, there's a package in R that you can use to, I can't remember which one, it's like the REST something, something, something. But again, it's easily found online. But there's a package that allows you to connect your API to R or SAS and let you bring it in and help you with those calculations and make the magic happen.
Thank you. All right. The main reference from Payne describes the development of the tool, but does not address human factor variables in the rollout of implementation. Were there any focus groups with potential researchers, clinicians, people with lived experience to evaluate the potential misuse of the tool?
There was not. Some of this was that, from our perspective, our research team was charged with trying to figure out how we would implement this CDE. And so it was something where focusing on the data collection and then aspects of how to do that in a way that was consistent and standard across different formats.
I will add that we did have colleagues from CDC advise on this based on their prior experiences with their calculator that has now been removed. So in terms of other clinicians or lived experience individuals, we did not, again, because this tool is used for research purposes only, the numbers generated by this tool should not impact patients. Right? Like the physicians and their care team are the ones directing their care. This is only to exist within the academic walls.
And
Thank
this
you,
is
Dr.
that a study has occurred, and this is how data is being collected for a study that is designed separately from this calculator. This is just how we structure the data that's been collected. The decision to collect that data and why you would collect that data is separate from the calculator.
Okay, we have another question here. Would it be useful to call the calculator something different to discourage clinical use? I can see students and others not on this call trying to use it.
We struggled with this a lot. It is a calculator, it calculates things. And so we unfortunately are not able to lock it down in a way that both allows the research community to use it for an intended use and completely prevent this use for clinical, other than to have warning labels on everything, cautionary on everything. And then, as we've mentioned, I mean, we're only 755 times in this webinar mentioning that it's not for clinical use. I'm sure we'll get the other 100 in, don't worry. But it's really just, it's not a replacement for human judgment and labeling.
Thank you. All right, how can we integrate the new HEAL MME calculator method with our existing data sets that's used previous opioid measures? And what approaches would you recommend for reconciling any differences between these metrics?
Kathy, do you want me to take that one? Okay. So what I'd say is if you already have, a database of information, this is the perfect application for using the API where it can use that. What you may need to do, though, is evaluate what is in the CRF, what is in the calculator in terms of like what the data collection fields are, and then transform your fields and labels into a version that would work with that. And so if you don't have, say, on therapy days, you're not going to be able to calculate that definition. But if you've got the drug and then the dosing, which they're pretty standard how the HEAL requested that this be collected, I think that you should be able to transform that information and convert what you already have into something that hopefully will give you that in a fairly seamless way. That was, again, the point of having not just the website, but the API that sort of has the underpinnings with it, allowing it to be exported to your own work and adapted that way.
So you basically need the drug, the dose, and how many days they took it.
Thank you, Dr. Sworden-Adams. And just a reminder, if you have any questions, please put them in the chat. And the next question we have is, would it be useful to call the sorry, I already read that. Has the HEAL MME calculator shown to yield consistent results when compared to central data collection and subsequent calculation?
So what they're really asking is, how well did we test the interface as compared to externally calculating? We ran this, probably a half a dozen times where we externally calculated the values and then we punched them into the calculator and made sure that the results came out the same.
And we did another round of it probably a month ago before we were sharing the link with anybody to make sure that everything was exactly as we'd like it, because that would be bad. And so that is not to say that there could not be some error, but this was tested many, many times in many different ways. But again, because we're not using it for clinical use, this will not impact patient care. This will be data analytics that you should be double checking and making sure that's working with your fields.
Thank you. Will this version of the MME conversion table be the one to use? What about the other conversion tables that are out there?
I think in the parameters of what the CDE program is requesting that people collect, and can happily hand that over to Dr. Wanner. I think that there are categories of information that they'd like. This is a way to do it. There is no requirement to use the REDCap or the calculator or the API. It's certain data collection.
Yeah, just seconding what Dr. Adams just said is that we are trying to use the best practice for the standard conversions right now, which is what it has been published in this article. So we have it's there as a recommendation to be able to use as a standard conversion. And the reason why we have these standard conversions for the HEAL CDE program is, as Dr. Su mentioned, that if the CDE or if a conversion is updated in the future, we can update those conversions in the calculator and can put out updated guidance in the future. But this way it helps us have consistent MMEs across all of the HEAL initiative, which is really what we are trying to do here, so that we can better compare the results of study A to study B to study C to study D in the future, also for secondary data analysis.
Thank you, Dr. Wadner and Dr. Adams.
I think in the future, if everything goes right and this is used, the hope will be there's a 2.0 that is informed by the research that this group is doing. And then, we would let everyone know and have those updates. It would be very transparent that there's 2.0, but that's the goal, is that the scientists, doing all their awesome work are going to find changes and things that help us do this better.
All right, next question we have is, how can you use the timeline followback in urine drug screens to convert to MME? Can you use MME across substances outside of opioids?
So this particular set of calculations is around oral administration or prescriptions. The urine values are like after it exits the system and not on the way in. So I wouldn't recommend that. And it is designed only for the specified drugs. I think the approach could be used in other situations, but these calculations and conversion factors were only addressing the known medications, oral, or as we mentioned, some transdermal medications.
Something that I'd also like to mention, I know for all those deep paper nerds that are going to dig in right after this, if you haven't, is that with these conversion factors, they were developed to go one way. So they were developed to go from a drug to morphine and create this MME. They are not meant to go drug A, morphine, to drug B, which is how in the past things have been done clinically. Again, please don't use this for clinical use. They're meant to be a one-way ticket to standardizing a dose to understand what's happening with research. And that's how they were developed on the front end. They were not meant to be something that showed you how to get to the other one. So the questions about things like tolerance and those types of things, they were really never developed for that purpose. People have used things, as we said, not for purpose, but it's important to recognize that the math, the little math that we have that supports this, is really meant to be a one-way conversion.
Thank you. All right. How do you access the calculator when institutional permissions aren't working?
That is a tricky question because what I do know is that a lot of different institutions have different levels of security. It may be something where you need to apply for an exception because you're using this for research purposes and allow it to be used for research purposes. And that, you know, in our institution, we have things that we have to go to Cybersecurity Council to get permission to use, like Google Drive. And so, you know, I can't speak to necessarily other than to investigate what the process is that might be blocking at your institution and then follow that process so that you're able to support your NIH funded work with this access.
Thank you. And how can, let's see, how can users access the REDCap data dictionary?
So the demo earlier showed searching for it on the CDE website. You can download the REDCap file. It's a zip file, and that can be uploaded into your local REDCap system.
Thank you, Dr. Sword. And then can the calculator be utilized or applied for specific pain conditions?
It's not, I think I'm wondering if the question is like, is it validated for certain pain conditions? It is not validated across specific diagnoses. So if it's a study where you're looking at opioid use for pain, it should be something that's broadly applicable because it's just like transforming the information that you're already collecting in your study into standardized information to be allowed to sort of combine with other data later. But it's not something that it changes the validity of the why the drug is being given.
Thank you. And what plans exist to monitor use of the calculator? If there are 100 HEAL projects, would it be expected the calculator will be used 100 times? What will happen if millions of conversions occur every month?
That's a great question. I would love to have that problem, right? So the only tracking we have is just behind the scenes analytics of access and components with that. We have turned that on as of a week ago just to sort of track and see what the dissemination and use of the tool is. And we will be keeping an eye on that as we go. But again, we're not tracking specific users or IP addresses or things like that, just, you know, opening the website, using the calculator and just basic components of that.
Wonderful. Thank you. And it looks like that's all the questions we have. If you have any more questions, please put them in the chat. There were specific questions that we received in the registration, and we'll send out the responses to those questions and all the questions asked today after this, as well as a how-to document and then a frequently asked questions. And do any of our presenters have any last items they want to reiterate or discuss prior to ending today's call?
I may have forgotten to mention this, but we shouldn't use it for clinical use.
Thank you, Dr. Adams.
Okay, well, with that, I just really want to thank our speakers. So thank you so much to all of the speakers here today, Dr. Adams, Dr. Seward, Dr. Suk, Ms. Conlon, and Ms. Bova. A lot of time and effort has been put into developing this calculator and making it available to all of the HEAL Pain funded researchers. So we very much appreciate all of the people attending this call and putting in their questions. We will be posting this recording online on the HEAL CDE website. So you'll be able to use this as a reference. And again, everybody who attended this call will be able to get access to the frequently asked questions, the slides, as well as additional materials. They will also be posted on the HEAL CDE website. So with that, we want to wrap up for today and just thank you all for your attendance and your hard work within this research community and your dedication to pain science. So thank you all. Have a great day.